Hello, welcome to my program. This is Dr. Hassel. I'm professor of pathology at the University of Oklahoma, and I'm glad you joined me for some digital slide review and sign out from an interesting case that came across my desk recently. The sample appeared to be a relatively routine sample, a patient postpartum undergoing a salpingectomy, having completed her childbearing goals. She was multiparous and had multiple prior births, some fairly close upon one another. And on inspecting her history, it was noted she'd also had a couple of episodes of associated abnormal bleeding, at times associated with what appeared to be pregnancy findings, at least serologically. But she had not been closely followed, and so there were some gaps in her history. This sample, I think, points out a couple of things that I think are very important from a professional standpoint for a pathologist. And that is that even though a sample may be routine and relatively poorly remunerated in terms of one's time or effort, that does not determine the kind of care and attention that a sample or a patient should get. Every one of our samples represents a patient. And so respect for the patient and respect for yourself as a professional should be manifest in the way that you handle even those very mundane and seemingly routine sorts of cases. And when the time arises, obtaining consultation, providing added workup, or other further examination of the sample to detect occult disease or to determine if some such thing is present, should not be withheld. So here's the case, salpingectomy. And as you can see, the tube has been resected, but there is an abnormality here affecting a portion of the lumen and the wall. It's a very pink abnormality. Looking at some of the other areas, you see it has a vaguely nodular and fibrinoid appearance, with intervening more cellular areas that have essentially displaced or destroyed a portion of the wall and displaced the normal internal fimbriated appearance of the tube. In some areas, it actually formed a little clot-like structure with areas of hemosiderin indicating prior bleeding. And you can see other areas that look like maybe a giant cell reaction or granulomatous type of reaction, along with these other areas of fibrin and hemorrhage with hemosiderin. So one might consider in this setting the possibility of salpingitis, granulomatous disease, or something of that sort. But overall, the pattern was, in fact, more suggestive of something else. So this multi-nodular hyaline pattern of fibrosis or hyaline change here in this lesion is very characteristic of what is seen postpartum in areas of the endometrium. The unusual thing here is seeing it in the tube. Here we can see that these, in fact, are not granulomata, but are little solid hyalinized nests surrounded by a degree of cellularity. And we'll take a look at some of those cells on higher magnification in a second. Well, right here. So here you see they have sort of homogeneous, mildly pleomorphic nuclei, a little bit of variation, and even some multinucleation in some of those areas, as well as the surrounding histiocytes and hemosiderin that we see here. Other areas of the lesion just show a very dense hyaline organized fibrin type of an appearance, with maybe a little bit of a surface epithelium that's regenerated around it. Here's more of this sort of change we see here. And you can see, compared to the normal fimbria, that they're not particularly involved by inflammation or other changes. Here at higher magnification, again, we can see occasional multinucleate cells and a degree of maybe entrapped or, heaven forbid, potentially infiltrative pattern of cells. But in fact, this is not an infiltrative pattern, though at some times it can very closely mimic an infiltrative neoplasm. again, similar appearance. And another image showing, again, these scattered nests of cells, the slightly cleared out cytoplasm that they tend to have in areas. And here, again, the degree of atypia that can be seen. So as you most likely have surmised, this represents what we term a placental site nodule, which is a hyaline scar-like tissue that becomes evident as the placental implantation site involutes, either following delivery of the child or, in this case, following an ectopic gestation. The challenge with these lesions is not that they exist, but that their presentation or our awareness of them clinically can oftentimes only come after a very long intervening lag time. We have seen this persist for multiple decades, 20, 30, maybe even longer, into the post-menopausal or at least well beyond childbearing age. And that happens because they will occasionally lead to abnormal bleeding or the appearance of a polyp. As you can imagine, they're poorly vascularized, but because of that, they may ulcerate or they may create a mechanical issue that leads to bleeding. And on occasion, the residual trophoblastic elements, those foamy cells and multinucleate cells, can appear somewhat atypical. And in the wrong setting or without awareness, we might consider them possibly squamous invasive neoplasia or something of that sort, because they can occasionally be P63 positive. Now, usually this is much less of a problem when we see it in the endometrium, but when it appears in other sites like the cervix, or as in this case in the fallopian tube, we may be a little bit flummoxed in terms of proper interpretation. I think this raises another interesting point, and that is relative to ectopic gestation. This is estimated to be actually a fairly frequent issue, comprising about 1% of all gestations. And we know that there are certain factors that predispose one to developing this issue. Prior infection or damage to the tube due to surgery or other factors, and smoking may increase the risk of developing an ectopic implantation. Some of these will resolve spontaneously, as it would appear has been the case in our patient. She was not, to our knowledge, treated with methotrexate or other pregnancy-interrupting drugs. So it's estimated that as many as 40% of ectopic pregnancies might even be managed conservatively or treated with methotrexate without requiring surgery. But our goal here is to reduce complications. We don't want a patient who bleeds out or develops shock due to that rupture of an ectopic pregnancy, while at the same time, many of these women in their childbearing years want to preserve fertility and the option for a future normal gestation. Surgical treatments have included both salpingectomy and salpingotomy. The jury seems to have indicated that there's not a significant difference in terms of subsequent fertility based on either of those treatments. And so that decision may rest with those who care for the patient and what they're familiar with and the specific circumstances of the case. So thank you very much for joining me. Our final diagnosis is placental site nodule of the fallopian tube, consistent with a prior ectopic gestation. And that is certainly an uncommon encounter, my first encounter with such a case that I thought would be worthy of sharing with you. Well, I hope you enjoyed that, and if you like that or have comments, please don't hesitate to share. We do hope and invite you to subscribe. You know the drill. Hit that subscribe button so that you'll catch any future releases from our channel. So until next time, thanks so much for joining me.